This PowerPoint primarily covers peripheral nervous system demyelinating disorders such as Guillain-Barré syndrome, chronic inflammatory demyelinating polyradiculopathy, and Charcot-Marie-Tooth disease. It also will have a very brief review of a central nervous system demyelinating disorder, multiple sclerosis. Guillain-Barré syndrome is an acute inflammatory demyelinating peripheral neuropathy. So basically, it damages Schwann cells of peripheral neurons. Guillain-Barré can be life-threatening if it affects the intercostal muscles or the autonomic nervous system. The characteristics of Guillain-Barré's disease is rapid ascending paralysis, means weakness, extreme weakness, begins in the hands or the feet, but mostly the feet, and rapidly advances towards the trunk. The pathogenesis of Guillain-Barré is that it is an autoimmune disorder. It attacks the peripheral nerves, specifically Schwann cells, and it is post-microorganism infection. The pathogenesis continued. Epidemiological evidence reveals that Guillain-Barré is linked to preceding infections with either Campylobacter jejuni, such as gastritis, cytomegalovirus, related to the herpes zoster, Epstein-Barr, as in mono, Mycoplasma pneumoniae, and recent vaccinations. So basically, Guillain-Barré is never an isolated peripheral demyelinating disorder. It is always associated with something else. Typically, a person will have had some kind of infection that I just listed and completely recover from it. And then about 14 days later, 10 to 14 days later, they would manifest the Guillain-Barré syndrome. Now, it's not always associated with these organisms that I mentioned. I have an example, a video that I put up where it is associated with a post-cesarean section, but it's always associated with something else. It's never completely isolated. Lab experiments have found that lymphocytes harvested from patients with Guillain-Barré syndrome will cause demyelinization of myelinated nerves in tissue cultures. What they did was they took frog neurons, myelinated frog neurons, and put them in a petri dish, and then they put lymphocytes from someone with Guillain-Barré that they isolated from their blood, and those lymphocytes immediately destroyed the myelin of the frog neurons. Kind of weird, isn't it? The morphology presents it is inflammation of the peripheral nerves. So the body is creating lymphocytes, macrophages, plasma cells, antibodies that are destroying the myelin cells or Schwann cells. And it is segmental demyelinization, so it doesn't really go from one point of the neuron to the other. It doesn't like start at the most terminal aspects and migrate in a retrograde fashion towards the cell body, or vice versa. It doesn't start at the axon hillock and then migrate anterograde toward the axon terminal. It can be spotty at different segments along the neuron where it's demyelinating that tissue. Histology will show the effects of the posterior and anterior spinal nerve roots. You can see on the left where the axon is demyelinated, you see all those circles there, and that shows where Schwann cells has been damaged. The cross-section of the axon on the right shows nice, tight wrappings of Schwann cells around that neuron, which is forming the myelin. Some clinical features, as I mentioned before, Guillain-Barré always precedes some kind of infection, and about 50 to 60% those individuals had a febrile illness about 10 to 14 days before the onset, and they completely recovered from that illness. I'm repeating myself, aren't I here? Ascending muscle weakness is one of the clinical features, and it is the major neurological sign. It'll start in the legs, particularly the feet first, and then it can hit the arms, and then actually get to the face. So it goes from the bottom up. Those individuals will have a completely absent deep tendon reflex because it's affecting the lower motor neurons. Lab findings will show that the nerve conduction test is slow or actually not even transmitting at all. And then cerebral spinal fluid will show an increased levels of protein. The etiology is the cause is actually really unknown. We don't know why the body turns on itself post these types of microorganism infections. The incidence is 0.6 to 2.4 cases per 100,000 in the US. It is considered the leading cause of non-acute traumatic related paralysis. It affects reasonably young adults, ages 30 to 50, but it can affect at any age, and male and female are equal in this etiology. About 2 to 5% can actually die of Guillain-Barré, as I mentioned in the beginning, and it's typically due to respiratory paralysis or some autonomic instability or cardiac arrest. About 20% will suffer some long-term disability. On this chart you see here is a disability scale specifically for Guillain-Barré syndrome. Moving on to the next condition, chronic inflammatory demyelinating polyradiculopathy. This is also an autoimmune disorder. It is symmetrical mixed sensory motor demyelinating polyneuropathy. That means it affects sensory neurons and motor neurons randomly all over the body. This condition must last more than 2 months to have it be labeled as chronic inflammatory. Otherwise, it would be an acute condition if it was less than 2 months. This could be chronic or residual from Guillain-Barré syndrome, as it is associated with that Guillain-Barré as well. You'll have to rule out acute Guillain-Barré for somebody who has chronic inflammatory demyelinating polyneuropathy. The CIDP morphology shows that it targets Schwann cells, just like Guillain-Barré does. It targets Schwann cells, it produces antibodies that destroys them randomly along the axon. The difference is with Guillain-Barré, it attacks neurons all over the body, causing paralysis, and it does it just one time, and then the body can heal from that. Where this condition, this chronic inflammatory demyelinating polyneuropathy, it will have exacerbations and remissions. That's kind of similar to multiple sclerosis that has exacerbations and remissions, but that only affects CNS neurons. So in this morphology, you'll have periods where the patient regains their strength and then periods of weakness again. With CIDP, immunosuppressive therapies directed against the T cells and B cells of the immune system shows a change or improvement of the remyelinization. The CIPD histology will show evidence of periods of demyelinization and remyelinization of Schwann cells. And when it does that, it gives what's called an onion bulb appearance. So it looks like a sliced onion, where you can see large rings, and there's a lot of space in between the rings because those are where the myelin has been destroyed, and then the darker areas is where the body has tried to add more or remyelinate it. So the big thing with CIPD or CIPD is that it is chronic. It is similar in its ascending paralysis or more like ascending weakness, and it comes and goes. Has periods of remyelinization and demyelinization, and it affects peripheral neurons, and it'll show an onion bulb appearance. Moving on to the next condition, Charcot-Marie tooth disease is the most common hereditary peripheral neuropathy. It is autosomal dominant, autosomal recessive. It is X-linked, so that means genetically you can get it in any of these combinations. It affects both sensory and motor neurons. The pattern of Charcot-Marie-Tooth disease is based on the mode of inheritance. There are so many. We're just going to talk a little bit about 3. You have CMT1, which is autosomal dominant. It typically manifests between the ages of 20 and 30, and it manifests as slow, progressive demyelinization. CMT2 is also autosomal dominant, and its onset is in early childhood. It affects the mitochondria that's inside the axon, leading to axonal degeneration, not demyelinization. The mitochondria within the axon just cannot produce the appropriate enzymes or energy that's necessary to maintain the axon. In CMTX, which is X-linked recessive, Charcot-Marie-Tooth disease, the onset is in childhood or adolescence, and it affects males a little bit more than females. And it specifically affects the gap junctions of Schwann cells. So it affects those Schwann cells being able to communicate with each other. The etiology is 1 in 2,500 people, so it's reasonably prevalent. It affects about 2.6 million people. Most likely you'll have at least one person in your practice that has this condition. There's no cure for it, but it's not fatal. They can have a normal life expectancy, which means chiropractic care is essential for them to help improve the quality of their life. CMT1 is the most common type of Charcot-Marie-Tooth disease. It represents about 60% of all cases of Charcot-Marie-Tooth disease. And it involves abnormal MPZ. Do you all remember myelin protein 0 from neural and muscle physiology? Remember that myelin protein 0 is an adhesive protein and is required to hold or link together all the layers of the Schwann cells. So what happens when you have this abnormal MPZ, it can't hold the Schwann cells together and they just unravel. CMTX, which is the second most common, but it only represents about 10 to 16% of all cases. So the clinical features of just about all of the CMTs is distal muscle atrophy. They'll have some sensory loss and some foot deformities. Here's an image of a foot deformity. It's showing a club foot or pes cavus, and it can have other foot deformities. Neurological findings will vary from patient to patient, also from type of CMT to type of CMT. These individuals will have a high steppage gait, an abnormal high steppage gait, and they can fall frequently, and they trip a lot. They'll have distal extremity weakness in their feet and their hands. They'll present with a waddling gait. They'll have some sensory loss. They could develop hammer toes. They could have high arches, or they could have flat feet, and they could also have an inverted heel. So whatever, just think about it. The muscles are weak because they're not getting the appropriate nerve intervention. Muscles have to have appropriate nerve signals or they don't function right. So if someone who has CMT, and they have periods of where it's demyelinated or the mitochondria is not functioning right, whatever is causing decreased signals to getting to these distal muscles, it's going to affect the development of those extremities. One of the major signs or red flags of CMT is muscle atrophy in the legs. Now, if you remember from anatomy, the structure of the lower extremity from the knee to the ankle is referred to as the leg, and from the hip to the knee is the thigh. So what happens is there's so much atrophy in the leg, and CMT only affects the really distal aspect of the extremity, so it doesn't affect the thigh muscles as much. So they developed what's called an inverted champagne bottle appearance, which is a classic sign. I saw it on a board question once a while ago. And so they have lots of atrophy of the legs, but no atrophy of the thighs. So someone thought it looked like an inverted champagne bottle. It also, CMT is going to affect hand fine motor skills. So it's difficult for a person to do fine motor skills, like pick up buttons off of a table or even button their clothes. It's difficult for them to hold utensils to eat, peel a banana, sew with a needle and thread. So it does significantly affect their hand fine motor skills. CMTs will also present with the onion bulb appearance. So this is the second condition. First was the chronic inflammatory demyelinating polyradiculopathy, because it had periods of exacerbations and remissions. And so does CMT. So it'll have periods of demyelinating and periods of remyelinating. So its histology of a neuron is going to show the same onion bulb appearance. So apparently, Jean-Martin Charcot, Pierre Marie, and Howard Henry Tooth all discovered this condition at the same time, and they could not agree on what to call it. They all failed at rock, paper, scissors, and so they decided to give it all of their names. So the disease is named after all three of the physicians who first identified it. The only reason I'm putting this in here is one time I solved this on an old board question, so I just wanted you guys to know that it had nothing to do with your teeth. It's not a dental problem. Now we're going to review multiple sclerosis. Multiple sclerosis is also an autoimmune disorder, but it mostly affects the central nervous system neurons. It can affect cranial nerves, but it really targets oligodendrocytes, not Schwann cells. It is the most common CNS demyelinating disorder. It also has exacerbations and remissions, but it will not show an onion bulb appearance, again, because it only affects Schwann cells. On MRI, you'll see reactive gliosis, which leads to sclerosis, which is scarring. It'll have slow nerve transmission, like you would see in Guillain-Barré, or you might see in chronic inflammatory demyelinating whatever that last one is. It is not lethal. Guillain-Barré can be lethal. CIDP is actually not really lethal either. And Charcot-Marie-Tooth disease is not lethal either. MS will affect females 2 times more than males, and it is a fairly young onset between ages of 20 and 50. And it has a high incidence like CMT does, where it can affect 1 in 1,000. But it is a geographically noted condition where individuals living above the 40th latitude have a more high prevalence of this condition than those who live closer to the equator. The main signs and symptoms for MS are unilateral visual impairment, muscle weakness, muscle spasm, and incontinence. So that covers it for demyelinating disorders.